Good morning. Today's topic of discussion is broad spectrum antibiotics. So far you have covered a lot of antimicrobial agents and which have different kinds of spectrum. So today we are going to discuss about broad spectrum antibiotics, and what you mean by broad spectrum antibiotics is that it can act against a wide array of organisms, that is gram positive, gram negative, and anaerobes. So in this class, we are mainly going to discuss about the mechanism of action, spectrum, pharmacokinetics, adverse drug reactions, and uses of broad spectrum antibiotics, mainly two groups, that is tetracyclines and chloramphenicol. So now, when we talk about the broad spectrum antibiotics, we have to first understand the steps of bacterial protein synthesis. So when you have studied about penicillin, you have seen that the penicillin was mainly acting against the cell wall synthesis. Similarly, cephalosporins were also acting against the cell wall synthesis in the bacteria. But now you are going to discuss a group of antimicrobial agents which are disrupting the bacterial protein synthesis process. For example, in macrolides also, you would have learned how they are disrupting the bacterial protein synthesis process. So first you have to understand the steps of protein synthesis that occurs in the bacteria, so that you can understand how these drugs are inhibiting the different steps of bacterial protein synthesis. So you already know that the bacterial ribosome has got two subunits, that is the 50S ribosome and the 30S ribosome. You also know that the transfer RNA is carrying the amino acids to the ribosomes for the protein synthesis. The ribosome has got A amino acyl site and a P peptidyl site. This is the basic information that you should know about the ribosome. And you also know that this ribosome is actually moving on the mRNA, which is having different codons, and so as per the change in the codons, you will have different amino acids added to the protein chain. That's the first step, is the chain elongation process, where the mRNA attaches, the mRNA you can see here, attaches the 30S ribosomal subunit to form the initiation complex. So you are here, what you are seeing is the formation of the initiation complex. And first you will have a nascent peptide chain. That is A1, A2, A3 amino acids. You can see this is a nascent peptide chain from where the protein synthesis begins. So this nascent amino acid chain is attached to the P site of the 50S ribosome. And the next amino acid, which is supposed to be added to this chain, is carried by the tRNA. You can see the A4 is carried by the tRNA, and it is attached to the A site. Okay, now the nascent peptide chain is then transferred from the P site to the A site, and it forms a peptide bond. You can see here the nascent peptide chain, which was there, A1, A2, A3, it is now shifted to the A site and it's attached to the A4 amino acid, which was brought by the tRNA. So now the chain elongation has happened. A1, A2, A3, A4. The chain has elongated. Next step is a translocation process, where the elongated peptide chain is transferred back to the P site, and the A site now becomes vacant. And during this time, what happens is the ribosome is jumping to the next codon on the mRNA. Okay, so now you can see here, it has jumped from the C4 to the C5 codon, and now the tRNA will bring a amino acid, which is like corresponding to the codon on the mRNA. A5 has come now, and the process will now continue. Again, the chain elongation process will happen. Again, translocation process will happen. And so a protein is completely synthesized in this manner. Okay, this is the explanation. Now we'll go to the drugs as such. Tetracyclines. This is the name of the class, tetracyclines. Okay, why it is called so? Because they have a nucleus of 4 hydrocarbon rings. You can see here as a figure. Their source is soil actinomycetes. Now, when we talk about the history, the first tetracycline which was used was chlorotetracycline. It is also called as oreomycin because it was having a yellow-colored colony. It was, obtained from a yellow-colored colony of Streptomyces oreofaciens. So it was golden in color. That is why it was called as oreomycin. In 1953, oxytetracycline was obtained from Streptomyces rhamnosus. Then in 1953, tetracycline, which is formed by the chemical modification of oxytetracycline, was developed. So it is a semi-synthetic one. So tetracyclines is the name of the group, and in that group, one example is tetracycline. Then 1967 came the most popular drug doxycycline, which is again semi-synthetic one. And later on, glycyl cyclines, of which digicycline is an example, was developed. So this one is a completely synthetic tetracycline. So this is the history. So by now you would have got the examples of tetracycline, that is chlortetracycline, oxytetracycline, tetracycline, doxycycline, and digicycline. Again, now we can classify. So we can classify into two types, based upon the T half and based upon the source. When we base it upon the T half, you can see short-acting ones include chlortetracycline, oxytetracycline, and tetracycline, which have a T half of 6 hours. Intermediate acting one is having a T half of 12 hours, and that is demiclocycline. Long acting ones include doxycycline, minocycline, tigecycline, which have a long T half of more than around 18 hours. Okay, when you now classify them as natural, semi-synthetic, and synthetic, you can see that chlortetracycline, oxytetracycline is purely natural. Tetracycline is classified as natural, but you know that it is formed by a chemical modification of the oxytetracycline. So it is not, in some books you will see it as a semi-synthetic one also, but in some books you will see it as a natural one because it is actually derived, it's only a chemical modification of oxytetracycline. Semi-synthetic ones include demiclocycline, doxycycline, and minocycline. Synthetic one is tigecycline. So just get the examples of tetracyclines clearly now itself. Chlortetracycline, oxytetracycline, tetracycline, demiclocycline, doxycycline, minocycline, and tigecycline. So we have discussed regarding the classification. Now, all tetracyclines, they are bitter solids. They are weakly water soluble, and you will not get aqueous solution because they are unstable. More of the chloride solutions are available. All the members of, that means all the drugs on tetracycline, they have got the same spectrum of activity with small differences. Means they will be active against the same organisms with subtle differences. The newer ones like the doxy, the mino, the digicycline, they have got high lipid solubility and greater potency. Now let us look at the mechanism of action of tetracyclines. You will see that the tetracyclines will get concentrated inside the organism. How they are getting into the organism is mainly through an energy-dependent active transport mechanism. After entering the organism, what they do is they will bind to the 30S ribosomal subunit, and they will prevent the binding of the amino acyl tRNA to the A site of the mRNA ribosome complex. So mainly what is happening is that the elongation part is somehow interrupted because they are going and binding to the 30S ribosome and preventing the binding of the new amino acid to the A site of the mRNA. So that inhibition happens and the further process of protein synthesis will not occur. They are all bacteriostatic. Remember that. It is static. Now, when you see, I talk about the spectrum, as I told you earlier, it's a broad spectrum drug. So what happens is that it is active against a lot of organisms. So gram-positive cocci, streptococcus, staphylococcus, gram-negative ones like gonococci, meningococci. All this you have to learn by heart, okay? Gram-positive bacilli, you can see Clostridium, Enterococci, Propionibacterium acne, which can cause acne in individuals, Bacillus anthracis, gram-negative bacilli like H. influenza, Brucella, Calamobacter, Vibrio cholera. Then a lot of other organisms like Rickettsia, Chlamydia, Mycoplasma, Actinomycetes, protozoa like Entamoeba histolytica, spirochetes like Treponema pallidum. All these are susceptible to tetracycline. Now, this spectrum, this activity is very important. You have to learn this by heart, because if you don't know the spectrum, you cannot write the uses, because the uses are a direct translation of the spectrum. Because see, if you look at the uses, I will show you the uses. Here I have colored blue colors. Okay, these are the most important organisms which against which tetracyclines are important. See, for example, Brucella. You will see it is active against brucellosis. Now you can see rickettsia. You can see that it is active against rickettsial infections like Rocky Mountain spotted fever, typhus, and Q fever. And you see chlamydia here. Chlamydia. It is active against chlamydian infections like LGV, trachoma, urethritis, cervicitis. Mycoplasma. It is active against atypical pneumonia due to mycoplasma. Calamity you can see it is active against granuloma inguinal caused by Calamity. You can see Vibrio cholera. It is active against cholera. Plague. You can see Yersinia pestis. Okay, so and due to Borrelia. So this the blue ones which I have marked here, these are the organisms against which the tetracycline is the drug of choice. Means that is the first drug that you're giving in such conditions. So you have to learn all the organisms, and then you can just write the infections caused by them. That's the first choice drug. Second choice drugs means tetracycline is active against these organisms or infections, but we don't use it as the first drug. We have other drugs which we will use, and we will use tetracyclines only if the other drug, the person has some allergy to the other drug, and only we will use. So this is the second choice drugs in tetanus, anthrax, actinomycosis, listeriasis. Penicillin is the first choice drug. So if suppose somebody is allergic to penicillin, so you have to go for a second choice drug, which is tetracycline. Again, the second choice drug to ceftriaxone for gonorrhea. It is a second choice drug for syphilis against penicillin. So you know that the first choice drug for syphilis is penicillin. So if penicillin, the person is allergic to penicillin, then the second choice drug will be to shift to tetracycline. It's a second choice drug for leptospirosis. It is a second choice drug for chancroid. It is a second choice drug for tularemia. And it's also used for amoebiasis, UTI, chloroquine-resistant falciparum malaria, acne vulgaris, and it is also used in a non-infectious condition, syndrome of inappropriate ADH secretion. In that, tetracycline called as demiclocycline is specifically used. So in the bracket, I have told you which particular tetracycline is used for that. So this uses of tetracycline is very, very important, and you cannot just pick here and then and write. You have to write the way I have given you here. First choice drugs in rickettsial infections, chlamydial infections, atypical pneumonia, granuloma inguinal, cholera, brucellosis, plague, relapsing fever. Second choice drug for tetanus, gonorrhea, syphilis, chancroid, tularemia, other uses. This is the way you have to write in the answer sheet. This is only a mnemonic, which might help you, but I don't really recommend a mnemonic always. But if you're finding it difficult to learn, you can as well use a mnemonic later on. Okay. Now, many of the drugs have developed many of the organisms have developed resistance to the tetracycline, mainly by different mechanisms. So, some bacteria can flex out the tetracycline. So, tetracycline will not be able to act. Some bacteria have developed a plasmid-mediated protection protein against tetracycline. And some bacteria have developed some tetracycline activating enzyme. So in such bacteria, tetracycline will not act, and these bacteria are referred to as resistant to tetracyclines. When you look at the pharmacokinetics, you can see that all the tetracyclines are incompletely absorbed from the gut, and the food interferes with their absorption. This is not so with the newer ones like doxycycline and minocycline. Tetracyclines have got a chelating property with calcium and metals. Also, so when you're giving a calcium tablet, you should not give tetracyclines very near to that, because that will form an insoluble complex and both will not be absorbed. Again, food like milk or iron supplement and zinc preparations, antacids, sucralfate, they can reduce the absorption of tetracycline. So whenever you are giving tetracycline, you should be careful that you space these the tetracycline and the food are the preparations like iron and zinc. They are widely distributed and they are concentrated in organs like liver, spleen, bone, and teeth. And minocycline drug is mainly concentrated in the fats. They are also crossing the placenta, so it can reach the fetus. Excretion is mainly through the kidney, except doxycycline and minocycline, which are excreted in the bile. Route of administration is mainly oral, but doxycycline and minocycline can also be given IV route. Now, again, the adverse drug reactions are very important. So there are a lot of adverse effects of the tetracyclines. The first one is irritative effects. So when you're giving it orally, it can cause GI disturbances like nausea, diarrhea, abdominal colic, and esophageal ulcer. If you're giving it by the IV route, it can cause thrombophlebitis. It can cause the organ damage to the liver, especially in pregnancy. The damage caused is called as acute hepatic necrosis, and in this regard, oxytetracycline is safer. It can cause kidney damage. In this regard, doxycycline is safer. So the liver also it is causing hepatotoxicity, it is causing nephrotoxicity, and there's something called as a Fanconi-like syndrome. That is, if you are giving tetracyclines beyond the expiry date, that can cause glycosuria, proteinuria, and aciduria. That is called as a Fanconi-like syndrome. So, out of tetracyclines, they have got metabolites like epitetracycline and hydrotetracycline and all, and these are the ones which are causing these symptoms, Fanconi-like syndrome. Some of the tetracycline can cause phototoxicity, skin rashes, and dermatitis when on exposure to sun, more with demiclocycline and doxycycline. So just remember DD for the phototoxic tetracyclines. Then a major effect is seen on the teeth and the bones. So this should not be given to children because it can affect the teeth. This is the image of the damage done to the teeth. So you can see that if from a pregnant lady is given a tetracycline, it can affect the teeth of the newborn. Means newborn means it can affect the teeth whenever they develop. So that can cause brown discoloration, and deciduous teeth will be ill-formed and more prone to caries. If given to the child from 3 months to 6 years of age, it can affect the crown of the permanent teeth and causing pigmentation and discoloration. And it can also cause depressed bone growth if tetracycline is given in pregnancy or childhood. So you can see that if the mother is also taking tetracycline, it can affect the child in the future in terms of the deformities developed in the teeth and the bone. So it should not be given to pregnant women, nor should it be given to children. It has got anti-anabolic effect. That is, it can cause negative nitrogen balance and can cause an increase in the blood urea. It can give a diabetes insipidus-like picture. And in this regard, demiclocycline is a drug which causes a diabetes insipidus-like picture. Some of the tetracyclines, like minocycline, can cause vestibular toxicity, like ataxia, vertigo, and nystagmus. It can cause increased intracranial tension in infants if it is given, and that is called as a pseudotomous tuber cerebrate that is characterized by bulging of the fontanelle, which gives an impression of a tumor. Very infrequently, it can cause hypersensitivity, and because it is broad spectrum, it can cause superinfection also. So again, you have to remember all the 10 ADRs, irritative effects, organ toxicity on the liver and the kidney, phototoxicity, effect on the teeth and the bones, anti-anabolic effect, diabetes insipidus, vestibular toxicity, increased ICT in infants, hypersensitivity, and superinfections. Now, it is contraindicated in pregnancy, lactation, and children up to 8 years of age because in pregnancy it can cause hepatic necrosis, and also if given in pregnancy, lactation, and children, it can cause damage to the bone and the teeth. It should not be given in patients suffering from renal and liver diseases. It should not be used beyond expiry date because if it is used, it can cause Fanconi-like syndrome, and it should not be used along with diuretics because it can predispose to increased blood urea. This is only a comparison of different tetracyclines. So I just read out the important points. You can refer that in your textbook and have a comparison. So you can see that there is a difference in the source, which I have already discussed in this. Doxy and mino are mainly semisynthetic. Then you can see potency. The newer ones are higher potency. Doxy and mino are more potent. And intestinal absorption also you can see it is more in the newer ones like doxy and minocycline. There is no interference by food also. Again, when you see the elimination, doxy is mainly excreted by the feces in the bile, and minocycline is mainly in the urine and the bile. The other ones are mainly by the renal excretion. Plasma T half, you can see as the newer ones are having more T half. Dosage you can remember later on, and you can see the super infection is least with the newer ones. Diarrhea also is low with the newer ones. For toxicity, doxy has got high for toxicity, and when you come talk about specific toxicity, you can see there is very less toxicity of renal with doxycycline. There is a higher toxicity of vestibular in case of minocycline. So this table is taken from KD Tripathi, and this you can compare. And it is very important because sometimes you might just get a short note on doxycycline. Instead of saying tetracycline, they can just talk about doxycycline. At that point, what will you write? I have mentioned this in many of the classes that whenever an individual drug is talked about, you have to say the class of the drug. You have to mention the mechanism of action, which we have discussed, the spectrum, which is common to all. Then you say the specific characteristic of that drug, like the toxicity, which is less, the pharmacokinetics from this table. And finally, you can consider the uses of the doxycycline, which is similar to the general uses that I have mentioned earlier. Digicycline is the synthetic tetracycline. It is one of the newest tetracyclines, and it is given mainly by the IV because it is new. Not much resistance has developed to it. It is safe in kidney disease also because it is mainly eliminated by in the bile. It is only used for serious infections. It is not kept for regular use, only for serious infections which are caused by resistant organisms. Now let us discuss about the chloramphenicol. So the source, initially it was obtained from Streptomyces venezuela, but now it is prepared synthetically. This is also a yellowish white crystalline solid, and it requires protection from the light. It is also very bitter in taste. Now, when you compare the mechanism of action of chloramphenicol with tetracycline, you can see it is attaching to the 50S ribosome near the acceptor site. The other one was binding to the 30S ribosome. It is interfering with the transfer of the elongating peptide chain to the A site and prevents the peptide bond formation between the elongating peptide chain and newly attached amino acids. So the mechanism is more or less very similar, but just that it is binding to the 50S ribosomal site, and this is preventing the attachment of the elongating one to the elongating peptide chain to the new amino acid at the A site. Okay, in the previous one we saw that it was preventing the attachment of the new amino acid to the A site. Here it is preventing the attachment of the elongating peptide chain to the amino acid that is attached already to the A site. Now, just remember that this is a very toxic drug, and at high doses, chloramphenicol can start attacking our cells also. That means the human cells also by preventing or inhibiting the mitochondrial protein synthesis, especially in the bone marrow cells. When you talk about the spectrum, all the organisms that I have mentioned in tetracycline should be repeatedly mentioned here, except the with a note that there are some differences. That is, it is highly effective against Salmonella typhi, more effective against H. influenza, Bacillus pertussis, Klebsiella, less active against gram-positive cocci and spirochetes, and not effective against chlamydia, entamoeba, and plasmodia. The entire spectrum can be written as such from tetracycline with the note which is written below. I don't want people to write this is the difference. When you're talking about chloramphenicol, we want the complete spectrum of the chloramphenicol. We don't want to hear what's the difference. Okay, so try to always stick to the question what is asked, because many often I see you just write the slide as such and not actually the spectrum. So this slide is not what we are requiring. I want the complete spectrum as such in tetracyclines, and then you can write differences from tetracycline as a note below the main spectrum. Now, the absorption, when you look, it is mainly can be given oral or parenteral, and wide distribution is there. It is mainly metabolized in the liver by conjugation, and the neonates and alcoholics whose enzymes are not functional or not developed, they find it difficult to conjugate the chloramphenicol, and hence in such individuals chloramphenicol can go to toxic levels because it is not adequately metabolized. The metabolite that is formed is excreted in the urine. T half is 3 to 5 hours. Now, chloramphenicol also has got a lot of ADRs. Just irritative effects are similar to tetracycline, but the main one is bone marrow suppression. It can cause aplastic anemia, agranulocytosis, thrombocytopenia, and pancytopenia. Now, the bone marrow depression can be non-dose related or dose and duration of therapy related. Now, if you're giving it a high dose and then the bone marrow suppression occurs, that is mainly occurring because of the direct toxic effect on the mitochondrial enzymes and in the erythropoietic cells. This is predictable and it is reversible without long-term sequelae. But in some individuals, even at a lower dose, this can happen. And this has got a genetic basis, and that is why it is called as an idiosyncratic myelosuppression. And this is unpredictable. You cannot really know which patient is going to develop that. And this can occur on more commonly on repeated use. It has got a high mortality, and even if survivors are there, they are prone to develop leukemias later on. Hypersensitivity reactions are also common. Superinfections can occur, and it's something called as the gray baby syndrome. It occurs when high doses are given to the neonates, especially premature neonates. So this neonate is not able to conjugate the chloramphenicol, and there is a toxic level of chloramphenicol in the blood. So the baby starts to vomit, it stops feeding, irregular respiration, there is abdominal distension, there is hypothermia, hypotonic baby. The baby becomes bluish gray in colors. There is cyanosis followed by CVS collapse. So this should be taken care of, and it should not be given to premature neonates. There are other better drugs which can be given for infections in premature neonates, but not chloramphenicol, because chloramphenicol fails to get metabolized in premature babies, and that can lead toxic levels, and that can lead to gray baby syndrome, which is highly mortal. Now, some of the precautions with chloramphenicol: never use for minor infections. Do not use for infections which are treated by which can be treated by other antimicrobial agents. Avoid repeated courses. Daily dose should not exceed 2 to 3 grams per day. Use for less than 2 weeks, and total dose should not exceed 28 grams. Regular blood count should be monitored whenever the patient is on chloramphenicol, and chloramphenicol should not be combined with any other with any other antimicrobial agent. The systemic use of chloramphenicol include mainly serious infections like pyogenic meningitis, anaerobic infections like those caused by bacteroides fragilis, and then intraocular infections, enteric fever, brucellosis, whooping cough. Topically, as creams and ointments, it's available for conjunctivitis and external ear infections. It should not be used on skin or other areas. So again, you can remember the systemic use of chloramphenicol. So these are the uses. So the main expected questions here are: tetracycline is very important, and examples, mechanism of action, spectrum, uses, and ADR. Spectrum, ADR, and uses are very commonly asked. So this should be taken note of. Doxycycline is a special note, short note. I've already told you how to write the answer. And chloramphenicol, since it is not very commonly used, you can expect mechanism of action, spectrum, ADR, especially the gray baby syndrome, and uses under chloramphenicol. That's all for the class. Thank you.